GI care, and advanced urology. We are also honored to have an excellent lineup of speakers joining us tonight, and we hope the session will be insightful, practical, and clinically useful for all participants. Before we begin, just a few quick housekeeping announcements. First, throughout the webinar, feel free to submit your question through the Q&A form, where we will be sharing over at the comments or the chat sessions. We will try our best to address as many questions as possible during the discussion sessions. Secondly, for doctors attending the CME accreditation purposes, please note that the attendance form will be released through the chat during the middle portion of the webinar. We kindly encourage everyone to fill out the attendance form once it is shared in order to facilitate the processing of your CME, SKP, attendance, and points. And finally, we sincerely thank all of you for spending your evening with us, and we hope tonight's session will provide valuable learning and meaningful discussion opportunities for everyone. Without further delay, let us begin tonight's webinar. So for our first speaker for tonight is Dr. Siaw Jann. Dr. Siaw is a senior family medicine specialist with more than 36 years of experience in clinical practice and medical informatics. He is also the founder and CEO of Mobile Health Network Solution and has contributed extensively to Singapore healthcare landscape through various Ministry of Health task force and advisory communities focusing on medical informatics and telemedicine. Tonight, Dr. Siaw will be sharing on treat the three highs, miss the one, and drive them all. Please join me in welcoming Dr. Siaw Jann. Hi, Dr. Siaw. You are on stage now.
Thanks, Alfred.
Yes, we can see you and the slides as well.
Okay. Thanks a lot, colleagues and friends across the region, from Singapore, Indonesia, and various parts of ASEAN countries. It is indeed a privilege for me to share with you some insight on, especially on the management of chronic diseases. Now, as our population age across the region, in fact, it is not uncommon to see patients that come to us with non-communicable disease, namely the chronic diseases in Singapore, in most of the region in ASEAN, we call it the three highs: diabetes, hypertension, hyperlipidemia. Basically, high sugar, high cholesterol, and high blood pressure. Now, I have encapsulated my topics to say that it is about time actually for us to shift our focus. We have been emphasizing a lot on how to manage, how to bring down the sugar, how to bring down the blood pressure, how to bring down the cholesterol of our patients. But a lot of time, we miss the one that drives them all. Now, I want to contextualize this speech, especially to ASEAN's context, namely the countries in ASEAN, which is relevant to where we practice, where we are now today. Now, why it is so important to us is because non-communicable disease, it is actually our daily bread and butter. A lot of times, we end up treating the patient when they are already being diagnosed, and we have to treat them medically. Now, it is a burden on our healthcare system. And in fact, if we look carefully, statistics have shown us that 80% of early death, in fact, in ASEAN, they are driven by cardiovascular, diabetes, cancer, and chronic respiratory, of which the three high contribute significantly. And another fact is that 1 in 5 of the adults in Southeast Asia are actually overweight. Now, this region is also unique. It is also a region where there's a rapid adoption of mobile technologies. This is why I want to put these talks in the context of how we use the technology to actually help us as primary care physician. Patients also increasingly to engage us by mobile platform and mobile technologies. Now, the reality dawned upon us as primary care physician is this. There are few startling facts that I want to put in context. The BMI that we take in ASEAN is definitely different from the BMI that the West, our Western counterparts, classify and group their patients in. In fact, a normal, seemingly normal BMI for our ASEAN population, they can still have high visceral fat and high cardiometabolic risk. And many a times for those of us who have practiced for many years in primary care, in our GP practices, you have noticed that obesity, diabetes, hypertension, and dyslipidemia cluster earlier and earlier. When I first practiced medicine, I see them in their 40s, 50s. I'm seeing a lot of them in their 30s, 40s, some as young as 20 plus. They're actually moving, becoming younger and younger now. They present to us at a younger and younger age. And in fact, a lot of them have a much lower cutoff BNI than our Western patients. And it is never easy to coordinate a proper delivery of care for our chronic patients with all these problems. Why? Because it is never a singular effort. It involves a multidisciplinary teams of public, privates. It's a very complex problem because patients have different affordability, different type of medicine are available, language barriers. These are all reality that we face day to day in our clinics. So as I contextualize them to the ASEAN context, now, one thing is unique. Although we come from different countries, Singapore's a modern, cosmopolitan, Indonesia's, Malaysia's, Thailand, Vietnam, Philippines, one thing is sure, the root cause, the pattern is shared. You see, in Singapore, we may be treating a lot of diabetes. We have a hard time trying to control it. And we know that the underlying root cause is actually weight. Weight is a big, huge problem. Similarly, in Malaysia, it is the high diabetes burden in Malaysia as well as Indonesia has a lot to do with the weight burden too. Now, if you're looking at Thailand, we have an aging population with a lot of chronic diseases. Now, uniquely for Vietnam and Philippines, although the population is much younger, but we know that the obesity rate and also is still rising. Now, so the common clinic question that we should be asking ourselves is not which country has the worst obesity. The problem is either dawning on us or it's already within us. In fact, we should shift the way that we approach problem is to which of our patient has untreated upstream metabolic risk. What I mean is we want to pick them up much earlier, even before they occur. By this is where truly primary care stands. This is actually where our strength will be shown fully and manifest greatly. Now, it is very important, as I mentioned in my earlier slide, that there's a huge big blind spot. A lot of time we are blinded by the BMI and say that the BMI is not too bad. We can expect a much higher BMI to our patients. Now, it is very important that we do not judge and grade our patient just by the weight alone. It is important to ask the progression of weight gain in our patient. Now, we are extremely privileged in primary care, whereby we track our patients, and many of us follow our patients since they are a kid, they are born, and we follow them until they age. In fact, one of the unique things being a GP is the patient age with us. Now, how many times have we seen that our patient actually also put on weight across the age? Most of them actually also gain weight. The trajectory of weight gain is absolutely important. In fact, that actually points to the upstream metabolic risk that will be surfacing as they grow older, you see. And how many times have we missed the fact that we have forgotten that on top of their height and weight, we have a look at their waist. We should take time to check their cholesterol and blood pressures and sugar level. Why? Because it is absolutely important for us to look for central obesities. Now, many of us fail to interpret the important variables in high TG and low HDL. It is important not just to look at cholesterol alone. By the time a patient has high cholesterol over the last 10 to 20 years, the cholesterol plaques have built up. What is key is a lot of time in the early test when we screen for our patient in their late 20s or early 30s, a lot of time the high TG and the low HDL should flag to us key things. The risk of a central obesity with possibility of fatty livers. Now, in this day and age where there are ability of easy screening tools, each and every one of a patient wherever possible, we should actually screen them early for fatty liver. These are early signs of central obesity on top of the traditional way of looking at treating the diabetes, hypertension, and high lipid when they already occur. Now, one last thing that I want to touch on is this. Many of us fail. Some of us may pick up the abnormal BMI. Some of us may pick up the central obesity, but many of us fail to treat clinical obesities. Now, I take a hard look at myself. Many a time, I have patients who are obese, BMI of 35, 40, 45. You see, I will just say, okay, please try to lose your weight next time. Watch your diet. Now, why I put this topic as treat the three high and forget about the most important one? It is important. For diabetes, we have a target of HbA1c we want to achieve. For blood pressure, we have a target that we want to achieve. For cholesterol, we have a target. Similarly, every follow-up visit in the clinic must visibly show that the target for weight loss has been achieved. You see, if we have a hard look at our own patients, we'll see that maybe we have managed to bring down the HbA1c to below 7, blood pressure below 135, 85, LDL of below 100 to 130. And yet, the weight remains in the obese range with BMI of 30, 35. And we never take any action, concrete action to make sure that similar measurable outcome is being achieved. So this is one key thing that I want to emphasize across is while we aim to treat the three high, we must aim to achieve at least visible reduction in weight loss across the visit. We'll have failed our patients if at the end of 1 year, 5 years, and 10 years, instead of losing weight, their BMI go up to morbid obesity. That is even worse. Now, so it is important also at the same time. Now, I want to shift the focus to the next thing now is, for us, especially in ASEAN, is many of our patients follow us since they are young. It is important to tell our patient that, not to tell our patient that, oh, you're overweight, your weight is high, you need to slim down. I think that's not enough. What we need to tell them now is this. Your metabolic risk pattern is active. What do I mean by this? We need to tell our patient that by not losing your weight, by not slimming down, your risk of heart attack, stroke, cancer will go up. And it is active, meaning every day it will add away the length of your life. Every day while you don't tackle this problem, it will actually more or less certain that eventual morbidity will occur. In a similar context of when we tell our patient, for example, your HbA1c, if not being brought down to below 8, we will expect possibility of hemodialysis to set in, to be required by in 8 to 10 years' time, you see. So in a similar context, we have to tell our patients that if the weight target is not being achieved, this is the consequence that I'm going to see in the next few years, 5 years, 10 years, you see. It is not enough just to tell our patient that you need to lose weight. Okay. Now, you see, I just want to recap. Many of us focus so much on treating diabetes, hypertension, high cholesterol. And this is the loop. You just loop around treating this day in and day out. It simply means our aim is always to give more medicine if the sugar is not well controlled. If the BP is not well controlled, I will increase from monotherapy to double to triple therapy, you see. More medicine, more visit. And have we asked our patients? In fact, a lot of patients becomes so demoralized and not motivated. Why do I need to increase medicine? But we've forgotten actually obesity, the driver is still active there. We have to look and tackle the main key driver. So I want us to reframe in this context that we no longer just treat the 3 high, we treat actually the 4 high. You see, when I manage to reduce the weight of a patient, a lot of time, you know what happened? Their high blood pressure medicine can be reduced. Their diabetes medicine can be reduced. I can reduce the dose of the cholesterol medicine. You see, it is very important. Instead of adding and compounding more medicine to the patients, by tackling the roots of weight, we actually help to reduce the medicine and increase compliance and leading to a satisfactory outcome. Now, if you look at it very carefully, right? Yeah, after I can't draw, but never mind. So, you can see that obesity is actually what I call the common soil beneath the 3 high. Obesity actually gives rise to insulin-resistant beta cell stress, the RAS and sympathetic activation, atherogenic dyslipidemia, subsequently leading to the 3 highs. Now, by tackling that, there's a huge potential to actually reduce your HbA1c, your blood pressure, your TG and LDL burden. Now, it is therefore very important for us as primary care physician, right, to actually move from organ by organ rescue. By the time diabetes has set in, we're trying to rescue the kidney, preventing renal failure. We should move this to upstream risk. Managing the risk before we have to manage the organ. And the risk is much easier to manage in this age of AI. I love AI, okay? So now, the thing that I want to touch on is very unique in the sense that I think we should capitalize on that to help us. Now, I just want to bring us into this perspective of obesity. It is no longer just a side diagnosis, okay? The scale or the global scale, right? Now, we're talking about 1 billion, 20% of the population is actually obese. And this number is increasingly, in 2020, the number will jump to 1.13 billion. And when we talk about overweight, we're dealing with almost 40 to 60% of the world population. What does this mean for all of us here as primary care physicians coming from different countries in ASEAN. Every diabetic patient that we see in our clinic is actually a chance for us to assess that based on their obesity-related drivers. Every hypertension actually should shift our focus to manage the risks involved: sleep, weight, and the diet that they eat. Every lipid patient gives us a chance to identify the hepatic central obesities and metabolic risk, you see. The question is, many of the doctors will ask, Doctor, my encounter with the patients, I can't spend half an hour talking to a patient or all these things. We don't have time to do all this. Yes. This is why I want to throw this to everybody. At your place of practice, in any way, wherever you are, in this age of AI, go and explore what should AI take off from my hands. I should utilize available tools so that it can help me to manage my patient much better than I'm alone. So I want to move our conversation now to the next. How I foresee the world AI can help us as primary care physician to take away a lot of this burden for us, to move our care upstream, to manage the patient risk, especially with respect to weight management. You see, obesity is right, weight problems, there are many causes here that can end up with. A lot of time, we have failed to explore all this with our patients. It can be metabolic cause because they are born with propensity with high TG. It can be behavioral because of the way they eat. It can be social because of the way they stress. They are having stress, shift work. Now, it can also be biological because there are different life cycles, menopausal, postpartum, and all this. As a doctors, right, a lot of time when we assess obesity, we fail to look at all the possible underlying factors. You see, as a doctors, right, we may say we don't have time to do all these things. I look at my role now in this age of AI and tools that's available to us is the AI must be able to surface the pattern and analyze this patient with overweight issue, with obesities. What is the underlying causes? Is it metabolic, behavioral, biological, and psychosocial? By gleaning the feedback from the patients. And the powerful AI will be able to personalize the conversation with the patients and keep the plan alive between the patient seeing us. And when the patient see me in the clinic, I basically need to confirm, your weight problem now is because of your behavioral. Nothing to do with genetic, nothing to do with stress. It's because of the way you eat, you see. So we did confirm what the AI has picked up for us. Then I prioritize how to treat and negotiate with the patients. Now, so you can see that the chronic care loop of what we used to do in the past. A diabetic patient come and see me, I will try to treat the diabetes and stop there. Maybe off the cuff, I will tell them, please take care of your weight and exercise more. That's it. Now, right, the possibility become endless to us in this age of artificial intelligence. We must have a tool where the patient can constantly interact with. And through this tool, the AI would have already know what is causing the problem. You already find out, because of the way they eat. Because this patient always upload the pictures, to the AI, every of his diet. So, every of his sleeping pattern is being captured. His parameter is being captured by the AI. AI will have also stratified now for us to say that, look, based on the patient risk, based on other parameters, this is slightly what he's facing. And the amazing part is the AI can do a lot of things for us even before the patient comes and see us. It can discuss, negotiate, and provide very personalized advice, contextualized to the countries, to the cultures. Now, every culture eat different type of food. We are not at the privy to know every different food in the region, you see. And the tools is something that is useful to nudge the patient to say that, look, I think today you better not eat this food. There's other food that's more available and healthier. We can't do that. We can only do that. Can we do all this in one visit when the patient comes? We can't. But what is unique is a powerful and useful AI tools will be able to pick up all this and alert the doctors, escalate it to us and say that, look, I find that this patient, based on all this, his lifestyle and everything, I discovered that his weight is getting worse, his risk is getting higher, and perhaps I also noticed that from his blood test, his is a potential of kidney deterioration. And it actually flagged to us as doctors, you see. Now, what I mentioned down there is, you see, a powerful AI tool should be able to sieve whatever information is available in this patient. May it be biophysical, laboratory imaging data, and compile something that is highly personalized to the patient, individualized to the patient, to us. Now, you can imagine with a tools, right? Before the patient see us, the AI will have passively detect anything unusual about this patient already, based on all the information that the AI can glean, and risk cluster the patient for us. Okay, to say that this patient is most likely pre-diabetic, we need to take care of it now. With central obesity, for example, or this patient has risk of hypertension because I've noticed that his BP is trending higher, and when he sleeps, he snores a lot, although he is only 30 years old. You see, so it already risk classified for us, and that is so crucial is because patients see us in episodically, once every 1 month, 2 months, 3 monthly, or even 6 monthly for some. What happened in between? There's no way we'll know unless we have a powerful tools that can track the patient in between visits, you see. And you can imagine that any patient that come and see us, we have this doctor-ready summary to prompt and remind us, this is the patient, this is the time we have to take action now. You see? So I can imagine that with such a powerful tools, right, that the patient actively participate in, it will transform the way that we see our patients in the future, from treating disease, established disease, to actually preempting risk and managing upstream risk factors. And not only that's so important is because each patient now can be individualized and personalized treatment. We can offer them this, you see. And this is something that I think in this age of AI and genetic agent, this is possible. And it can be localized somewhere to the local food, culture, language. Now, you see, the AI can advise and become a very powerful tool to help lifestyle modification. See, advising patient which alternative food to eat, alert them if they don't have a good sleep, what they need to do. It can also prompt them to join certain support group, to see a dietitian, and do a lot of digital coaching. And in fact, it can also flag to us any permutation of medication that is not correct. For example, in a patient with diabetes, maybe shouldn't be given this particular medicine that will worsen his diabetes, you see. Now, this is very important. We do not have the time in one consultation across only one visit to glean all this information to the patient, you see. But a powerful AI tools can definitely do that. And then, of course, ultimately, we can now focus our intention on the patient alone, you see, and say, look, I want to treat your, let's say, for example, obesity. I want to make sure you slim down. We will do what matter the most for the patient during the encounters, you see. So it is important for us to remember that we have to be realistic in dealing with our patients in our clinic. Now, for all of us who have been seeing our patients for many, many years, right, we know that the best plan to the patient is never the most ideal plan. We can never achieve everything ideal, but it is important to make sure that it is a safe plan that is sustainable. You see, a lot of time we cannot ask our patient to lose weight until normal BMI, or we can ask the patient to lose weight until they are healthy. You see, until a weight that they think that they are happy with, they are healthy, they looks healthier, they looks better, and it's sustainable. It is not realistic. Now, a small step is better than something that a bigger step that is not achievable. It is important to do that. So I always tell my patient, if you can lose 3 kilo in the next 6 months, I'll be very happy. Although ideally I want him to lose 5 kilo in the next 6 months, you see. I think it is important to make sure that our goal is always to deliver the safest of plan that is sustainable. Now I want to bring this down to this, okay? Now, in mobile health network solution, right? Coming from my IT background, it is my vision and dream that every patient will have a AI tools in the form of an AI companion. So we have created this empathic ICO AI companions that is truly localized, multilingual, and human-centered. ICO, as it evolved in the Manadoc app, you will find that it is able now to sift through all that the patient has provided within one app. The remote face scan that will capture their stress level, their sleep pattern, their BP heart rate. The photograph that the patient has uploaded to look for the calorie counts, the exercise, the work that the patient has been taking every day. All this, right, can be assimilated by the AI. And particularly, it will actually be able to tell the patient, look, today I don't think you should be eating this hawker center food, it's too oily. Maybe your dinner can eat something lighter. Now, this is something very powerful that we can't do it on our own, but the AI can do it. A good, well-trained AI companion can do this on our behalf. Okay? And the AI can also prone that maybe this weekend you should stay at home and don't eat out because they discovered that this patient has been eating out. And it is also very important. In the local dialect languages, it can actually tell the patient, look, maybe you should eat this today in the local context. You know, in Mandarin, in Bahasa Indonesia, in Vietnamese. And that's make the patient's compliance rate to increase, you see. And what is most important is this, it can also pick up any friction detection. As let's say, for example, this patient now has very low mood, didn't sleep well, and the test can show that the patient is actually very stressed. Now you can see this, a good AI companion, the moment they pick this thing up and they feel that this is not good and safe, and patient is getting worse, you will escalate to the doctors, you see, to us as a doctors. And that is the day where I envision each and every one of our patients will have such a companion, so that any upstream risk will be picked up much earlier. So you can imagine that as this patient ages down the years, right, we find that, hey, how come the patient is putting on weight 4 to 5 kilo every the last 4 years? You have flagged to us that we expect the patient by the time, patient may be 60 kilo, by the time in 5 years time, it may be 90 kilo. But before that happened, we have been flagged to say the patient put on weight dramatically over the last 1 year. We have already intervened when the patient comes and see us, you see. You have been escalated to us. And this pattern trending is so important. Now, at the same time, we are also developing a tool for the doctors, which we call the doctor's advisors. Now, you can imagine that if in our clinic now, right, when I'm seeing this patient right in front of me, a 35 years old gentleman with a BMI of 35. But before the patient stepped in, because this patient has been using this tool for a long time, the AI advisors or the co-pilots for the doctor who have already prone me to say that, look, this is a man with the following summary. His weight is increasing over the last 1 year, and his last few blood tests actually show that his TG is getting worse. You may want to do some things. So during consultation, this will have been flagged to me. He will also advise to me that, look, this patient has been eating all this food. You may want to advise him to take this certain diet which is available locally in this place. At present, we ask our patient to eat healthily, right? Many of time, actually, it falls short, far short. You know why? Imagine I can give the patient a list and say, look, I think you should eat healthily, but this is the 7 places available in this hawker center where you can eat them. So you can imagine AI can assist. These are the 7 places around near your place where you find healthier food, you see. Now, it is very important. During consultation, we have a tool that's as powerful as this to further enhance our care. And imagine after consultations, right? After I see patient everything, all this will be sent automatically to the AI companion to say that this is your plan, this is the thing that you must be doing, without us actually spending a lot of time telling the patient what to do. The AI will nudge, the AI will guide, and we are there only to reinforce, you see. Now, what is even more important is between consult, right? Today I come to clinics now, I should have a companion that flag to me that, look, these are the patients that I have failed to see them in the last 6 months. I should have been seeing them on a 3-monthly incident because their result is no good, their weight is increasing. Why am I not seeing them? Or why have they missed appointment to see me, you see? So this is very important. To have an optimal care of patient, we do not have the mental capacity to track patient. But our tools, our AI companion for the doctors can do that. Now, it is very important to remember this. AI had to reduce our cognitive and clerical friction. It cannot add on additional work. We are just there in the loop to be the guardrail, to be the master, to be the checks and balances, ultimately to make sure that the right care is being delivered. Now, it is very important. This is a caption that I think, do you know that we manage a patient now, right? AI should allow us to manage a population of patients around the area that stay with us, or a population of patients within our clinics, you see. What do I mean by this? We can't be just seeing the patient in front of us today. Now, it is too reactive. patient come and see me today for this problem. I believe an AI would be able to. Now, I have classified this as something that is for you to think through. Now, you can see that the AI should be able to sift through all my patients' record, look through all the panel segment, and say that these are the patients with the following problems. And then it gives context to the patient problems and advise me on the clinical action that I should be taking and what is the outcome that it should be tracked, you see. Now, what do I mean by all this? You will go to my next slide. Now, this is very important. You see, when we manage a patient, AI allows us to manage a population. What do I mean by this? A lot of times, right, at present, when we look at our patients, we look, okay, this patient is treated that way. HbA1c is correct. But have you asked yourself, do you know how many % of your patients that you manage have they reached the target of good HbA1c control, good weight control? Now, that is where we translate our care from individual patient care to clinic-based, population-based care. So you can imagine that AI will allow us to grade the clinical care, the behavioral care, operation care of our patient, and actually plot out in graph to say that, look, out of this, all your patients, only 20% have achieved their target weight. The remaining 80% has not. So we shift our mindset now to manage one single patient, to look at the groups of all our patients within our population of care. So the powerful thing is this. How it shift is this now. Our mindset is, look, my clinic is not good. 80% of my patient is overweight. I need to do something about it. And 70% of my patient has only reached their ideal target HbA1c, or 30% only. And worse still, BP control of my patient is only 20% have reached target. Have I been too lax with them? Now, this is so important for us is because it allows us to see across the spectrum of how we manage our practices, how we manage the population. And you can see how AI can help us to do this, you see. So you can imagine every day at the end of the week or every time at the end of the month, you get a report and say that how have you managed your patients across the board? How and where have you managed the families, you see? Now, I'm going to end here now is, I want to challenge every one of us here. We don't just treat the 3 high. We must remember that obesity is one of the bigger high here. That's the first thing. The second thing I want to highlight is we have to use AI as a tool in whatever form. Every one of us have to embrace it, whether be it the AI companion for the patient in the form of ICO, AI advisor that we're trying to create within our electronic medical record, to move the level of care from treating the disease to moving upstream to picking up, clustering the metabolic risk. Treat it before the organ damage set in, before the disease process starts. And not only that, we have to utilize AI to make sure that the care is personalized and individualized. Ultimately, right, as a doctors, our point is to prioritize the care, what matters the most in our context of our understanding of our patients' environment, the context of their families, of their support, and deliver the right care with AI as our co-pilot, you see. So, in this context, right, you will see drastically how our care can shift from treating organ damage to now fully focus on what matters most. To me, is that obesity first prevention must be a routine, safe, measurable, and scalable outcome for all of us in the ASEAN region. Yeah. And I would encourage every one of us to embrace AI, every one of us to actually look at obesity as the soil that actually worsen the three condition. And I want to challenge every one of us now to move our care from giving individualized patient care to actually manage the population of patients within our practices, within the community around us. Yeah, I think I'll end here. So we welcome any question. Now later on, right, I think in the interval break, we want to showcase what we have as a company done with this AI lab. Now, for the first time, we are going to roll out tools for every single doctors where you can upload your patients' lab data and everything across times. Using this tool, the AI will be able to help you to predict, looking for possibility of comorbidity, trending, and estimate the outcome with evidence-based source to assist us to better manage our patients. And I hope this is one small little step of a much bigger things to come for all of us in primary care. Thank you.
All right, thank you, Dr. Siaw.
Yeah.
So yeah, thank you, Dr. Siaw, for the insightful session. So there are actually questions, but I think we'll move it to the later part. Right, we'll consolidate the question first, then after that we will do the Q&A. So before we move to our next speaker, we would like to invite our valuable partner first, Medisys, to share an innovative solution that's helping improve medication administration and patient care. Please join me in welcoming JB from Medisys team to take us through their presentation.
Thank you, Alfred.
Hi, JB.
How are you?
Great. Right, thank you. Nice to see you. Right,
nice
so
to see you too. Thank you.
Right.
So I'm Dr. Jaroslav Boblik. Everyone calls me JB. I'm here to present some information to you about the Medisys MyCare system. So, sorry, I'm just getting used to next slide. There we are. So a little background on myself. I'm a biomedical scientist. I started my career in drug development back in the mid-80s and worked in that field for about 10 years before moving into nutritional medicine about 30 years ago. In the interim, I've founded several companies in the nutritional medicine field and consulted to many more, both as a researcher and a product developer. Most recently, I've moved really into the boardroom, providing corporate advice, and just recently joined the Medisys Human Health Advisory Board to help them formulate the rollout strategy and assist in the presentation of this fantastic technology, such as we'll do tonight. Alfred, if we can show the first video, that will give you a good background.
When people can't swallow a tablet, traditionally they've been crushing it, and the crushing method's been a little bit inconsistent. Medisys is a great way of converting those tablets into a liquid without having those horrible little residues. So not only people that can't swallow, but people who are just sick of taking tablets. It's basically changed their lives. One particular patient that we've got who's on 6 medications, and he just stopped taking his medicines. He'd be running late for lunches and appointments and often would say, "Oh, bugger it, I'll take it later on." Now what he does, he puts all his medicines into the Medisys, goes, has his shower, has his shave, comes back, has his drinks, and he's out the door. We've tested quite a few medicines at the pharmacy, and they vary from between the 4 minutes, 2 minutes to the 8 minutes. And the more medicines we put into the machine, the longer it's got to stay in there. The machine's so easy to use, you just put it in, you press a button, that's it. The doctors that know about Medassist are actually quite excited about it because of the compliance component. One of the biggest things with any patients is trying to get them to take the medication regularly. We've got to do whatever it takes, and Medassist is one of the tools.
So that brief video gives you a little background. What we wanted to do now was contextualise that in terms of the ASEAN region. Now, medication administration hasn't fundamentally changed over 100 years. And in your region, the ASEAN region, there's a problem that's really affecting populations all over the world, and that's the ageing of the population and what comes with that is increasing rates of dysphagia, the inability to swallow, polypharmacy, the use of multiple drugs, and medication non-adherence. The ASEAN region is home to approximately 55 to 60 million people aged 65 years or older, and by 2050, this group is expected to more than double to around 135 million and accounting for 20% of the total population. So for those who struggle to swallow solid medications, traditional crushing, which is typically what people do, unfortunately results in inconsistent results. It's quite arduous, and it's certainly not aligned with modern medication safety. Now, with this growing elderly population in the ASEAN region, we're seeing increases in dysphagia, the swallowing disorders, increase in chronic diseases, polypharmacy, medication non-adherence, and all of this goes hand in hand with increasing number of hospital admissions and healthcare and increasing healthcare expenditure, and a huge increase in demand for both home care, community care, and aged care services. The number of older results requiring safer and easier medication administration is expected to more than double over the next period. What we can see on this slide is the incidence of dysphagia, or the inability to swallow. It's about 13 to 34% in the general population, depending on how it's defined. In nursing homes, this rises to 50%. It's very common in certain conditions, such as Parkinson's, where it represents about 39% of patients. In stroke patients, roughly 50%. And in those with specific esophageal diseases, 15 to 20%. For chronically unwell, medication adherence is already a major problem. We know that about 60% of people with chronic diseases have difficulty adhering to their medication requirements, and this is 48% in those with hypertension taking their antihypertensives, and 56% in people with diabetes. So this percentage of patients that fail to take medication correctly and consistently is quite substantial. And while we don't have a single study showing the exact global percentage attributable solely to swallowing problems, the literature consistently identifies it as one of the most physical problems. It's also a problem because many people won't report it to their physician. Swallowing difficulty is unique because it is a physical barrier. Patients will often want to take their medicines, but simply cannot to do so comfortably or safely swallow tablets or capsules. And instead, they either skip doses, delay doses, crush tablets inappropriately or have their carers do so, open capsules, stop therapy completely, and frequently avoid telling clinicians that they have a problem. Several studies have found that physicians and pharmacists fail to identify the majority of patients with pill swallowing difficulties because it's just simply a question that they don't ask. We estimate the annual economic burden across the ASEAN region as a combination of direct and indirect costs. Direct costs are around 25 to 40 billion US a year. Indirect costs, which are lost productivity, disability, premature mortality, and caregiver burden, another 35 to 60 billion. And so we have a total economic burden of up to $100 billion per year across the region. Many people resort to crushing hard tablets in order to make them easier to swallow. And the problem with this is that traditional crushing creates medication dose loss. Depending on how the crushing is done, either with some machines or more typically with a mortar and pestle, medication losses can be up to 50%. There's cross-contamination of powder. This is very problematic in multi-patient environments like aged care. There's also occupational exposure if the crushing is done by a caregiver, where they may be exposed to a medicine that they don't need, and that can result in some issues for them. We obviously get a very inconsistent particle size. It takes quite a lot of physical work to actually crush many medicines into a consistent particle size, and those inconsistent particles will often block PEG tubes if they're in use. There are lost efficiency, just the time that it's taken up with the carer looking after this process of crushing medications takes up a lot of time, and ultimately poor patient comfort because the gritty ground medicines aren't very much better than whole tablets. And so we come to the Metasys system, which uses ultrasonic energy, and solid medications become a homogeneous suspension without the variability associated with traditional manual crushing. And this addresses this issue of dysphagia and medication safety and adherence across your region. It's a very simple system. It consists of the Metasys MyCare unit, together with disposable beakers, which reduce the possibility of cross-contamination. And while most medicines can be simply dispersed into water, adding a flavour often improves the compliance for the consumption of the mixed medicines. And for some medicines where the taste of the dispersed material is not good, the masking flavours actually make the whole system work much better. The key differentiator with the Metasys system is we get 98% of the dose volume into the dispersed liquid, which results in, which comes from consistent particle sizes, repeatability. It's a machine that will consistently do this work day in and day out in a very repeatable fashion, and it is a closed and very hygienic system. With crushing, we have huge losses of dose. It's dependent very much on the skill of the operator, requires operator time, can create some aerosols which provide that occupational risk, and it is actually quite physically taxing work to crush large numbers of medicines, often the situation in an aged care facility. Now, Alfred, if we can show the second video, we'll actually hear from a Metasys user, Ross.
I've been on medication for a lot of years, some small tablets, but a number of large tablets. I would choke when trying to swallow my 5 night tablets, at least 3 out of 5 days. It's hell. Wasn't so hard for my morning tablets because I'd have those with a coffee, but night was always the drama. Tablets that I used to be on 1,000 milligram metformin were 25 mil long by 10 mil wide, so horse pills. Cut them in half, but it was still too big. But man, this device, as far as I'm concerned, has saved my life.
So just recapping, Metasys converts solid medications into stable liquid formulations, preserving dose accuracy. It improves adherence by eliminating tablet swallowing barriers, reduces unsafe medication manipulations such as crushing, modified release or enteric-coated tablets. It improves the continuity of care, allowing patients to stay on the same therapy, whether they're in a hospital situation, in a rehab situation, in aged care, or in home care and community settings where often the requirement of crushing the tablets causes them to drop their medication or therapy, resulting in obviously poor outcomes when they transition into those settings. And it particularly supports high-risk population, including people with dysphagia, stroke, Parkinson's, and those people using PEG feeds. We think Metasys can provide benefits across a continuum of care: aged care and community care, in-home care, hospital care, and pharmacy care. So we believe that it's time that medication administration evolved as much as modern medicine has. The incredible improvements in modern medicine from a technological point of view hasn't been kept up with the simple features of dosing with a hard tablet. And we think that Metasys can go a long way to addressing that need. And so we look forward to your inquiry. Thank you.
Hi, thank you, JB, for your sharing. Right, so for doctors who are interested, right, interested in the product, do mark it over at the attendance form, so Metasys team will be able to contact you for the on the products. Right, thank you, JB.
Excellent. Thank you.
Right. Thank you, JB. Right. So for our next speaker for tonight, it will be Dr. Jann. So Dr. Jann is a urologist with a subspecialty focus on bridge prostate hypoplastis, right, which is called BPH, and minimally invasive surgery therapies, MIST. It has extensive experience in managing lower urinary tract symptoms, LUTS, and is actively involved in advancing this-based prostate sparing procedure. Dr. Lee conduct training and CME session to bridge the gap between urologists and primary care, with a practical emphasis on timely referral and optimizing patient outcome. Tonight, he will speak on MIST opportunities, minimally invasive solution for enlarged prostate. Please join me in welcoming Dr. Fang Jann.
Alfred, thank you for the kind invitation. I've shared my screen. Can it show?
Give me a second. Right, it's up.
Okay, thank you so much. Thank you, Mother Doc, for inviting me for the session. Hi, everybody that's logging in and joining us. I'm a urologist by training. It's a great opportunity for me to be here to share with you this topic on missed opportunities, minimally invasive surgical treatment solution for enlarged prostate. Okay, so the outline of my talk, I'll be talking a little bit about evolution of BPH management or benign prostate hyperplasia management, some new modality of treatment that has come on stream in the recent years that some of our colleagues may not know, some future modalities, exciting modalities that may be coming on stream, and how the care of patients with prostate enlargement has a shift in recent years to a patient-centric care model. All right, so we are very familiar with the prevalence of BPH in general. The as a guide, we'll say that about 50% of male population by the age of 50, they will develop some degree of prostate enlargement. And by and large, by the time you reach the ripe old age of 80, 90, about 100%, great majority of men will have some degree of prostate enlargement, okay? It is the most common cause of male lower urinary tract symptoms. Any older gentleman that comes with you with lower urinary symptoms, if we are to make a side bet or small bet, if you bet on a BPH, by and large, it's quite likely that you get a etiology for the lower urinary tract symptoms correct. Okay, we usually connect lower urinary tract symptoms with regards to BPH with voiding symptoms or obstructive symptoms, things like slow stream, splitting of stream, intermittent stream, hesitancy, straining to pass urine or terminal dribble. But by and large, in a lot of primary care setting or even a urology care setting, what drives a patient to come and see us is more of the storage symptoms or the irritative symptoms that cause them to go to a toilet multiple times in a day, or even waking up at night to go to the toilet, like nocturia, urgency symptoms, and occasionally urge incontinence. Okay. I remember when we started my training about 20 years ago, this is the primary presentation for patients coming to us with BPH. They present to the emergency department with acute urinary retentions, whereby we have to insert in a catheter, they are warded in the hospital, they wait for a available list, and they undergo a TURP or third procedure to treat the prostate enlargement. Most of us who has undergone training in a hospital setting as a trainee will be familiar with the third procedure or transurethral resection of the prostate. What happens in the procedure is we introduce a resectoscope or a telescopic instruments into the penis, examine the entire urinary tract, and see where the obstruction from the prostate is, and go on to resect and open up a channel for the patient. All right. This device actually has a cutting loop at the end of it. Okay, and this is the typical appearance of obstructing prostate. The left lobe and the right lobe, and the median lobe, which is the bottom lobe that's sticking out and actually occluding the lumen. You aim your loop at the obstruction and you go on and trim it down, okay, like a excavation exercise, okay, until at the end you have a wide channel. You have certainty that there's no longer any blockage, and the patient is able to pee. All right. Having done the resection, what happened is that we usually change it to a ball electrode. This is an electrode that actually helps hemostasis and stop the bleeding. Any vascular points on the wall, we call it a roller ball. We roll over it, and that actually helps stops any bleeding. They usually have a urinary catheter inserted, and they are put on continuous bladder irrigation overnight, right? So as a trainee, this is one of the basic, the most common operation, and that we need to be trained in and we need to be very competent in. And one of the KPIs typically of our training, or what we take pride in, is how much chips we actually resect. These are actually weighed. The more you actually resect, the heavier the tissue that's resected, and they will send for histology for testing to make sure that we didn't miss out some form of prostate cancer malignancy. All right. Okay. So that procedure deals with all kind of prostate enlargement, not just the lateral lobe obstruction, the trilobar obstruction that has both the lobes and the bottom sticking out. This actually, the prostate TURP procedure or third procedure deals with all of them. You see, whatever actually sticks into a lumen, they get resected and the channel get opened up. It may be a median loop hypertrophy or medium bar or even a subcervical nodule. The TURP procedures deal with all of them very well. Okay, and if you compare the flow, this is another measures that we look at in terms of how well we've done the job. We want to establish from the baseline of a poor stream flow. Actually, there's very, very low peak and take a long time to pee. Okay, from a prostate obstruction, this is a bladder, this is a prostate that actually sticks out into the bladder, to post-operation, whereby there's a cavity seen within the prostate and a good flow. This is a sign that, other than the subjective assessment from the patient, the report that, hey, I'm passing urine well, these are a very objective measurement of how well you've done the job improving the flow. But it is not without complications. Okay, I'm sure a lot of us, when we're doing posting in the hospital as a houseman, what we dread is after being on call, a surgical call, and on a day whereby there is a TURP list by the urologist. Okay, without fail, it may be called to attend to a patient who go into clot retention. They have to do a bladder washout or bladder irrigation. Okay, so TURP has some complications that are more common than others. It is mandatory. There are a lot of times when we do a TURP, we need to tell them about the most common complications or expected complication, which is the ejaculatory disorder, which can occur in about 70%. This is what we call as retrograde ejaculation. Okay, what is that? Okay, so basically, if you look at the side profile of the diagram, the bladder, this is where the bladder is, this is the urine passage, and this is the prostate. With the prostate intact during ejaculation, okay, the prostate actually acts like a backstop. Any ejaculation that occurs, there's a tendency of an ease of passage for the semen to actually flow forward through the urethra, okay, because the prostate acts like a backstop and stop the semen from going back into the bladder. But with having a TURP being performed, the whole cavity opens up and there becomes an area of low resistance for backflow of semen. So what happens after the surgery is a lot of patients will complain of very little ejaculate or even a dry ejaculate. Okay, the reason is not because they're not producing any more semen. It's just that during the ejaculation phase, a lot of semen actually goes in the bladder and they get voided up after ejaculation. Okay, there's no harm to health, but it'll be difficult for them to may impair the ability to have natural conception subsequent to the procedure. Okay, there's also a risk of erectile dysfunction. You can see in this diagram the bladder, the prostate, and the cavernosa nerves. Actually, the supplies, the penis actually runs quite close to the capsule of the prostate. If you do a resection quite aggressively, some of the heat energy can possibly transfer to the cavernosa nerve and result in some degree of erectile dysfunction. Okay, stress incontinence can occur, and this is something that a lot of patients worry about. In a lot of the early days during surgical training, the urologists, when they are too aggressive in terms of resection, this can occur. Okay, so this is the bladder, that's the prostate cavity, and this is the pelvic floor muscles that controls the continence. Okay, if you do a very aggressive resection, cutting very distally, it may cause injury to the sphincter mechanism and resulting in this stress incontinence issue. With experience, more established urologists, this kind of thing do not happen anymore, right? There's also a risk of stricture with the instrumentation, especially a long procedure and a relatively small caliber urethra, with the instrument being inside there for extended period, anything more than 1.5 to 2 hours at the end of surgery, there may be a risk of stricture formation over time, right? Of course, risk of the need for anesthesia for procedure, hospital stay, the need for catheter for 1 to 2 days, okay? And over time, there are things that we've done to improve the technology in terms of TURP. We'll move on from monopolar TURP to something called bipolar TURP, using saline for irrigation instead of glycine. to minimize the risk of something called TUR syndrome or hyponatremia, dilution hyponatremia in patients that can put them at risk of getting convulsions and requiring ICU stay. Okay, this requires a modification technique because the electrical energy actually runs within the system, actually runs back and creates a very, very nice arc, and actually it cuts differently. And so we have to, in terms of learning, after we have mastered monopolar TURP, we have to adjust some of the technique to learn this new way of doing a TURP, but of course, for the safety of patient, right? Okay. In terms of instrumentation, there are also things they can do to vary. Instead of a cutting loop, they modified it into like a little button, a mushroom button that we use, and change the procedure to something called a transurethral vaporization procedure. Rather than cutting, we can use it to vaporize the tissue. You can tell that, with this technique, there tend to be a lot less bleeding incidents. Patients at risk of bleeding, and this may be a technique or choice to use to minimize the risk of post-operative bleeding. But as you can see, again, we have to learn a different technique to deal with the prostate. You have to slowly pass the button over the prostate to allow it to vaporize the tissue rather than cutting it. So this is a little bit slower. For huge prostate, this may not be a good choice because it will take too long, right? Okay. There's also things that we modify because we've seen with TURP after 10, 15, 20 years, there's a tendency for the prostate to grow back and cause obstruction. So we're going on to a enucleation technique to try to enucleate the entire BPH nodule rather than resetting it and creating a channel. If you do a full enucleation, this is a pushing technique that you start from the distal end, actually push it out and remove the entire transitional zone of the prostate or the nodular area of the prostate. There's a lower incidence of recurrence of BPH years down the road. Okay, all right. Many of you also have heard of something called a HOLAP, a holmium laser enucleation technique. So instead of using a loop, what we do is we use a holmium laser and use it to cut the tissue and push the tissue and complete the enucleation procedure. Again, this requires a mounting a new learning curve. And with HOLAP procedures, we found that we can do a lot more, a better and more complete job at removing all the obstructing adenoma, and there's very, very low risk of regrowth of prostate. But this procedure comes with a slightly increased risk of stress urinary incontinence because we start off very, very close to the apex of the prostate, close to where the sphincter is, and we push it too hard. Sometimes we have a little bit of damage to the sphincter muscles. Okay. If you use a different energy device, okay, so this is called a green light energy, or this is a side-firing laser. We can use this laser to actually melt tissue. This is like externally outside the body, it can look like a lightsaber. There's a green fiber, and for patients who are anticoagulation, that can't be stopped. They have a recent cardiac event that they need to remain on antiplatelet. This is a good option to avoid them of the obstruction, so that they do not have to depend on the urinary catheter, right? Okay. Okay. So over the years, we'll notice that with all this new technology and new treatment options, the number of TURP has been declining. These are US data, okay? With new modalities like laser, vaporization, coagulation, tuner, you can see that TURP numbers did decrease, okay? Is it still the gold standard treatment? Okay, so in the US, there are about 12.4 million moderate to severe BPH patients being managed on a yearly basis. Only 2% actually choose to undergo a TURP procedure, okay? And maybe another 1% will choose some alternative intervention, okay? Majority of them had chosen to be on medical therapy and has remained on medical therapy, all right? Why? What's the reason? Okay, when we do a survey on this man, most of them would have chosen to be on medical therapy and postpone any surgical treatment because of the risk of sexual side effects and the worry of urinary incontinence, okay? So these are, and medical therapy, okay, the primary form of medical therapy that we have available to treat BPH are alpha blocker therapy and 5-alpha reductase inhibitor therapy. This work in terms of reducing symptoms, and they work by different mechanism. Alpha blocker therapy relaxes the urethra smooth muscle, very fast acting. Okay, there are medication. The different medications in this class include tamsulosin, silodosin, doxazosine, terazosin, and fluzosin. Okay, because our alpha blocker mechanism, they also have side effects that we have to worry about. Postural hypotension, dizziness, a bit of rhinitis are common. We have to be careful if we institute this therapy in older gentlemen. They stand up too quickly, especially at night. There is a risk for them fainting, right? So that's what we worry about. And of course, alpha blocker therapy, the more selective alpha blocker therapy, they do have retrograde ejaculation, which a lot of men do not like. 5-alpha reductase inhibitors works by shrinking the prostate over time. The common 5 ARI include finasteride and dutasteride, and because of the mechanism of action, they have a lot of sexual side effect, which again a lot of men do not like, right? Okay. So what medical therapy does is delaying the progression of prostate enlargement, but it does not stop the prostate enlargement at its track. You're just pushing the need for surgical intervention from an earlier stage till you are at a later age group. Okay, but so how do we modulate this conundrum that we have? Okay, if you look at this chart, I like this chart because if you look at something that's safe and low morbidity like medical therapy, and that has lower symptom relief and flow changes versus something that works very well in relieving symptoms and flow, but with higher risk of complications. Is there a middle ground? And yes, there is. These are things called minimally invasive surgical treatment in prostate treatment, or we call it MIS in short. Okay, and what are they? There are quite a few that has come on board over the recent years. Why would patients choose to have this treatment? Okay, so what do they want in terms of BPH treatment? In an ideal situation, they want a treatment option that has no sexual dysfunction, no risk of incontinence. Ideally, it's outpatient treatment that doesn't require them to stay in hospital. Obviously, quick recovery. No need for long-term medication, of course, and they want the treatment to be durable. Okay, has MIS achieved this? They achieved some of the modalities, but not all. All have the pros and cons. Let's go through some of them. Okay, first one I'm going to go through is something called a Urology procedure. A lot of the audience probably have heard of it and have got wind of it. The patients probably have asked you about it even, right? So what is this? This Urology is something called a prostate urethral lift procedure. So what it is a permanent implant that is placed within the prostate. Okay, so what it does, it works by pulling the prostate apart, anchor it against the external capsule, and opening the channel as it is. It is a quick procedure. It takes about 10-15 minutes under local anesthetic or light sedation. Patients do not need to stay in hospital. And because of its mechanism of action, there's immediate relief of the occluding prostate. Majority of patients can go home without the need for catheter. Okay, the durability of results, the 5 years data shows that the reintervention rate is about 13%, which means over the course of the 5 years, about 2 to 3% a year of failure rate. So this is a before and after how it looks like. Okay, and of course the benefit, because of its mechanism of action, is touted to have no sexual side effects. Okay, this is how it looks like. If we put a camera through the urethra, looking into the channel, this is how the lateral lobe of prostate causing obstruction and having the urolith implant introduced, the channel actually opens up. A lot of times, you're keen to keep, we call that a window ties, okay? Instead of, like a window tie letting light in, we are letting the urine flow through, okay? This is an analogy that I give to a patient who undergo this therapy. Another option would be something called a resume therapy, which is a steam therapy, okay? So what it is using a device that with a needle, we introduce in the urethra and we inject steam into the prostate. And the steam distributes itself within the tissue plane, within the transitional zone, and over time, because of change in the state from a gaseous state, a steam state, to a liquid state, that actually release a lot of the thermal energy that causes a lot of tissue necrosis within the prostate. Okay, so this is how it look like. It's done under a sedation. It takes about 5 to 10 minutes. So looking at where the prostate is just sticking out, we introduce a needle in. Steam is actually introduced in the tissue over the course of 9 seconds. Okay, and then at the end of it, it is withdrawn. Okay, and then we move on to treat another area. So very quick procedure. Because of the nature of the treatment, a lot of heat is introduced in the prostate. One of the downside of the treatment is that a lot of swelling can be expected within the prostate, to the point that in general the patients will not be able to pass urine after the procedure. So they can expect to need a catheter for 5 to 7 days, and outpatient basis we have it removed. There will be some degree of discomfort with urination. Okay, a lot of burning, fair bit of burning, some blood in the urine, pain or urination after the procedure up to 2 weeks, a good retention or ejaculation, and 5 years retrieval rate is at a low rate of about 4.4%. And the good thing about this MIST procedure is that it's one of those procedures that actually has documented volume reduction, because it does cause tissue necrosis. If we do a measurement of the prostate volume at the end of 6 months, there's an average reduction of the prostate volume by about a third or so. All right. You can tell both the treatment actually works on lateral lobe of the prostate obstruction. So if you look at a typical illustration that we see in any textbook, normal prostate, enlarged prostate, most animations or diagram will show you prostate obstruction means both sides of the prostate on the left and right coming together and cause occlusion. But as a urologist, when we do a cystoscopy, we can see that there's many versions of obstruction. It may not be just lateral lobe like this. Okay, if we plug a camera inside there, parking at the verum montanum, and this is a prostate gland. This is an unobstructed prostate. We should be able to see all the way into the bladder. Okay, it can be the obstruction may be due to something called a high bladder neck, whereby the back wall actually flips up and cause blockage rather than lateral. And of course, it can be the typical lateral wall enlargement like this, which initial 2 techniques may be useful, or it can be a median lobe obstruction like a little ball actually growing from the bottom up. Okay, for cases whereby it is a high bladder neck or median lobe obstruction, there may be another MIST procedure that may be suitable. This is something called an ITIN procedure. It's a temporary implanted nitinol device that's introduced into the bladder. Okay, it's like a 3-prong device that you deploy in the bladder, and subsequently they can pull back and actually sits within the prostate. It deals with the patients with high bladder neck very well, because with the 3 prongs, it actually presses the high bladder neck down, actually cuts groove within it to relieve the obstruction. Okay, so with this procedure, it takes about, typically on average, about 7 to 10 minutes. And this device, once inserted, is left within the urethra for 5 to 7 days, during which it remodels the tissues and make groove within it through an ischemic necrosis process. Over the course of the 5 to 7 days, cuts are made into the prostate, and subsequent to which, at the end of treatment, outpatient basis through a catheter, this device is removed. Okay, it works well in selected cases with high bladder neck, and upon removal, we find that the urine streams actually improve. The durability study, this thing has been on the market for about 3 to 4 years. The durability study is up to about 4 years or so, and no sexual side effects. Again, right? Okay. So another modality is something called prolif thermal dilatation procedure. This is a new generation microwave therapy machine that not just deliver microwave therapy to the prostate to shrink the prostate. It also has a thermal dilatation effect during the treatment to act as a biological splint to improve the effect of the traditional microwave therapy. Okay, so in this treatment, it takes about 45 minutes. You have this dilator that's introduced into the urethra. Okay, it doesn't just have a retaining balloon like a typical urethra catheter. It has a balloon to expand the prostate, and during which you emit microwave energy. Machine treatment, all by the machine. And how do you modulate the energy? By a rectal probe that's inserted in the rectum. It actually measures the temperature and actually have an auto shutdown when the temperature increase to about 42 degrees to make sure that there's no overheating effect and all the energy is delivered within the prostate itself. Okay, so again, 45 minutes treatment. Most of the time, these treatments are done under local anesthetic nowadays. At the end of the procedure, the patient may have some spasm, some soreness, a bit of blood in the urine for 2 weeks or so. Again, no sexual side effects. Majority of patients at the end of the procedure peeing okay, no problem. Very durable studies, 5 years, no progression in 83%. Okay. An alternative then is patients who are really adverse to having anything inserted into the urethra or really unfit for anesthesia. Prostate artery embolization may be an option. So this is not new treatment options. Back in the days in 1995, in the 1990s, we have explored it and used it to treat fibroids. And since 2000, it's been implemented it's been experimented and established to use treat prostate enlargement. Okay, these are typically procedures that are done by interventional radiologists who has interest in this. The take-up is not great. The main reason is because the prostate arterial anatomy, vascular anatomy is so varied. Okay, there's so many variation in arterial branches. In order to get to it and treat the right one, it takes a lot of time. Okay, so the pros for it: minimal blood loss. It can be day surgery. There are no issues with retrograde ejaculation. Patients with anticoagulation are okay to undergo it. Okay, cons obviously technically challenging. During the procedure, there are a lot of hemodynamic changes in the collateral that makes the embolization procedures very challenging. Cause radiation exposure. Typical procedure will take out more than about 2 hours because the number of vessels they need to identify and actually occlude. Complications include perineal pain because this causes a fair bit of ischemia in the perineum. They may have a post-embolization syndrome, like fever and leukocytosis. If they treated too aggressively, treated the wrong blood vessel that supplies the rectum and bladder, there may be there are some case report of partial necrosis. Okay, coming soon. There are also new modalities like this is called aquablation using water to treat prostate. Okay, so this is a robotic platform that does it. Okay, so with a rectal ultrasound to guide and actually do the planning, we insert the device into the urethra. Okay, and using ultrasound, we actually do a mapping and plan out the area of treatment. Okay, how far it extends to, the area they extend where the prostate is, and we press a button, and what will happen then is the machine will commence treating the prostate automatically to the set margins that you have marked out. Okay, it works like a windscreen wiper. Okay, or you can see a power cleaner that we see on the market, right? So this actually vaporizes the prostate tissue, leaving a lot of the collagen and blood vessels alone. Okay, now the whole thing is automated. At the end of treatment, as you vaporize it, this device actually suck all the tissues and blood out and actually get passed out. At the end, the issue a lot of times with what you're left with the fair bit of mushy prostate tissue that you require a little bit of hemostasis, leaving a catheter in, but it does a very good job and clearing the entire prostate without the surgeon needing to do anything. The machine actually does it after your planning. All right. So a lot of modalities we talked about, but typically what it means to a clinical practice for urology now is that as a urologist, we do have to constantly keep abreast with the current treatment options. Because the options are so varied and so many, you also translate to a lot longer consultation, and we have to do a more careful assessment of patients to see what is suitable for them. If they're considering this, a lot of times they may need an additional cystoscopy to assess the degree of obstruction and what kind of obstruction they have to see what is suitable for them, right? Okay, so a lot of consideration nowadays, not just the prostate anatomy and size and general health, whether they can undergo anesthesia. Okay, the patient needs some input in terms of whether they want to preserve the sexual function, is continence, risk of continence important to them? Are they averse to having an implant in situ? Okay, having a catheter for a few days, is it a problem? Okay, can they tolerate anesthesia? Do they want outpatient procedure or inpatient stay? How fast the recovery, and so on and so forth. Okay, so a lot of times we can compare to what the urologist do, like a hairstylist. Okay, so a hairstylist, they cut hair for the patient's or the client's ego, not their own. Okay, so like a urologist, then we treat the LUTs for the patient's well-being. Okay, not for ours. What we fancy, what we like, is what the patient wants. Okay, so in summary, in this current day and age, TURP or TURP should not be the default surgical treatment option anymore. Patient-centric care is important. They need we need some input from them regarding their sexual function requirements, how durable they need the treatment to be, and whether they are averse to catheter or LA procedure. Okay, the patient needs to be part of the decision-making process, and hence nowadays the gold standard for BPH treatment is offering a portfolio or options to the patient. Okay, thank you.
Thank you, Dr. Lee. Right. So we will hold some of the question first. Then Dr. Lee, after that, we will invite you back on stage to answer the question.
Yeah.
Right. But for now, I will add Dr. Siaw on stage first. So Dr. Siaw will have there are some questions for Dr. Siaw. Right.
Yeah. Thanks, Alfred.
Yes. Hi, Dr. Siaw. Right. So a few questions for you. So one of the question is, how can primary care doctors detect these silent risk before hypertension, diabetes, and cholesterolemia become yeah.
Yeah, thanks, Alfred. So I think, as I mentioned in my talk just now, I think one of the key things is there's no person better than primary care doctors to pick this up. In fact, I presented my talk in such a way that we used to treat and see disease when they come to us. Established diabetes, established hypertension, established high cholesterol. We have to shift our mindset now, reframe our thought now to move the picking up of this risk factor and actively look for them. Now, we are privileged in the sense that many of our patients come and see us since they are young. As we track them, we have the privilege of knowledge to know their family history. We have the privilege to know their associated risk factor, their lifestyle since they are young. And we can see whether they are growing broader, taller, in many aspects, as they see us down the years, you see. And if we actively look for that, we should be able to find that who has high TG if we do early screenings when they are young. And if there's a need, we look for fatty livers and we look for central adiposities, you see. Now, this is crucial. This is why I want to frame our talk to that. Instead of just treating the disease, we should be looking for risk factor and manage them even when they appear to surface. So the other question is, in this age of AI, right? Now, it requires a lot of change in the way we approach medicine, especially in primary care, to pick up risk factor than to treat disease, you see. But things become much more exciting in the age of AI now. This is why we want to encourage our patients to utilize tools to track their lifestyle. An AI that tracks sleep pattern, that tracks changes in weight, dietary pattern, and that patients constantly, routinely do a scan of their face. Now, an AI face scan nowadays, the accuracy of picking up abnormal blood pressure, picking up stress, picking up abnormal sleep pattern, and picking up even cholesterol level as well as HbA1c can be done without a laboratory intervention. And I'm very certain these remote diagnostic tools will become better and better with passing times. We have implemented some of these tools for almost 3 years in some of our practices and the way we assess our patients. So you can see that in the era of the dawn of AI, as a doctors in primary care, we should actively look for such powerful tools to ask the patient to update them so that even before the patient see us, the tools will have really prompt us that we are dealing with patients with a higher risk of developing metabolic symptoms, you see, disease, even before they occur. Such tool is definitely available now, and we have to look for it, actively search for it, and you can always check with us what we are doing now to pick up a disease even before it occurs. And it requires a matter of mind shift, of how we deal with all this. Yes. And I think we live in exciting time of it, and fellows, colleagues, that finally we can actually deal with things, and we can have a lot of tools at our disposals, so that we don't have to spend too much of our time trying to decipher what is wrong with our patients, but we have tools that can automatically help us to decipher, and as a doctors, we can spend more of our time caring, talking to the patients, and engaging the patients in a more humane, empathetic way. Thanks.
Thanks, Dr. Siaw. Right, so for the AI tools that Dr. Siaw is talking about, next we will be, I will have my colleague, Edmund, our product manager, to join us. He will be sharing about Metabolic AI Lab and how AI-powered laboratory data analysis can support clinicians with faster, smarter, and more informed decision-making. Right, so let me invite Edmund to stage.
Hi, hello. Hi, okay, so Edmund here. Yeah. Alfred, can you help me to share my slide?
This slide.
Yeah, okay. Yeah, so basically today I will share a bit about the AI Power Lab data tool. Okay. So basically is a Gen AI diagnostic support system, right, that we built on GCP to basically help automate the patient history of lab report as well as to identify clinical risk early. Okay. So there's actually a few challenges with manual lab reviews nowadays in the clinic setting. So the two main ones are basically clinical inefficiency and also misdiagnosis. So as a clinician, right, you normally have to sift through like lots and lots of lab reports and lots of data. So this actually takes up a lot of workload burden on the doctor, and it actually can disrupt their day-to-day workflow. Okay. And when you have a lot of data to sift through, sometimes there will be cases of error prone, so they might risk overlooking vital trend indicators or even anomalies. Okay, so that may result in incomplete diagnosis. Okay, so the solution that we have here is basically a AI tool that can actually analyze the lab report and then generate a summary with comprehensive historical summaries. Okay, and not only that, when you continuously upload new reports, right, the AI tool actually understands all the past data alongside the current input that can actually generate a comprehensive summary. Okay, and not only that, it can also give structured report and also map the data points to give you a trend as well. Okay, so this basically shows the 6 pillars of the analytical reports. Okay, so one of it will be the abnormality detection. Okay, basically it can highlight out of range biomarkers, like maybe the cholesterol is on a high side or low side, for example. Okay, then we also have the trend analysis. So basically it plots the markers over time. Let's say, for example, you have a patient who has done a lab test in maybe a few years ago, and then one every year after that. So you can actually, when you upload the lab report, you can actually plot the different data points. So it can actually show you whether is the patient condition improving or worsening. So from there, you actually get a big picture of the patient's condition. Okay, and we also have a correlation of diagnosis. So that actually is we do like a trend. So we have a trend diagnosis correlation as well as the okay. So sorry. So for correlation, we have diagnosis correlation. So basically, it interprets the interconnected results based on trend and also the results to basically come up to suggest like probable patterns for this patient. Okay, and the fourth one will be external references. So once the AI actually generates the summary, it actually also references from a external source of medical database and publication to actually give you a insight of the of this patient. Okay, and the fifth one, basically it also highlights the list of potential diagnoses for this patient. So based on the data points that the AI actually captured, it can actually suggest what are the potential diagnoses. And lastly, in the summary itself, it can also suggest the next steps that the clinician should take for the patient. Okay. And in the AI tool, basically we have actually on the interaction layer, right? We also have this thing called speech to text input. So instead of typing, you can actually use your speech to ask question directly. Okay, and it also has this contextual patient memory. So it basically understands the patient's cumulative medical history, and it can actually answer questions without losing the historical references. Yeah. Okay. So yeah. So basically, this is just a overview of the differences between a clinician sifting through large amount of lab reports and versus if you use this AI tool. Okay, so you can see that review time basically improves a lot. Okay, because of the automated report and the query response. It also does trend tracking, so it can actually provide precise data consolidation. Okay, and interaction style, we can have the speech to text type prompting. And for clinical risks, because this gives you a overview, right? So you will not have any clinical risk due to, let's say, fatigue oversight. Okay. So next I will show you a video of how it looks like. Yeah, Alfred, can we to share the video? Yeah, so you can see here, it's basically uploading the lab report. And we will analyze all the different data points. And it will then generate the executive summary. Yeah, so that's the end of the video. Yep. Yeah, thanks, Alfred.
All right, thank you, Edmund. For doctors who are interested in our AI lab, please feel free to let us know. We will share it with you. So before going to our next speaker, we would like to invite Dr. Jann to come back to stage. There are questions for him. So let us welcome back Dr. Jann.
Thank you,
Hi,
Alfred.
Dr. Lee.
Yep.
Yes, so there are questions for you.
Yes, I'm seeing a few questions. So one participant asked the question, many patients are more concerned about losing sexual function than the surgery itself. How do you counsel patients when balancing symptom relief when present with preservation of ejaculation and erectile function? Okay, so if preservation of sexual function is paramount, then obviously the choice of technique in terms of treatment, needs to be one that actually have the lowest risk of sexual function or ejaculation impediment. So if there's a paramount, then the choice will be very clear and restricted to those, and all the rest of the parameters will be secondary in nature. So that will be the end of discussion. Even if the durability is not going to be as good, even if the efficacy is not going to be as good, if the overriding consideration for the patient is no impact on erection and ejaculation, then this is what the patient is will be agreeable to accept. And if as and when the treatment fails after a duration of time, there is always an option to undergo retreatment. Or you can see over the last few years, there's so many treatment options that has come on stream. It may come a time within a year or two, there may even be a better treatment that comes along that the patient is suitable for, that has a better efficacy for him then. Okay. Second question, if two procedures provide similar symptom relief, but one better preserves sexual function and allows faster recovery, should that become the preferred option for younger and sexually active patients? That will, in theory, okay. So that is quite a obvious thing that most people would consider. But when we actually sit down and speak to a lot of the patients, some of the fears and considerations can be quite irrational. Some patients will tell me that, hey, whatever you do, I don't want a catheter. Okay, their consideration is at the end of the procedure, they don't want to wake up with a urinary catheter. So if that's the case, then I need to pick a procedure that actually avoids the need for catheter, right? There are patients obviously who also will consider, hey, I want something that is durable. I want to do it once and it can last me for at least 5 to 10 years. Then, sexual function, he says, it's not so important. I'm completing my family, my sex drive is coming down, my wife doesn't want me to touch her, for instance, and things like that. We can come on board, and then the sexual function bit becomes a slightly lower priority for some of them, right? For the third question, okay, so for steam and microwave technique, will the prostatic fluid be reduced such that the ejaculate volume is reduced? With a lot of ablative technique, yes, we do see that in terms of ejaculation volume and concentration, there's going to be a slight reduction. Very similar to some of the patients that you put on 5-ARI therapy for medical therapy of prostate enlargement. After a certain duration of treatment, if you do ask the patient, a lot of them will do report that the semen is not as thick, and the volume tends to reduce a little bit. This is a known consequence of the treatment. Yeah.
Okay, so yeah, Dr. Lee have answered all the questions. Then we'll move to our next speaker. So thank you, Dr. Lee. Right.
Thank you.
Thank you. Right, so our next speaker will be Dr. Priska. Hang on, Right. So let me introduce Dr. Priska, Natalia. So Dr. Priska will be our final speaker. Dr. Priska is a general practitioner, medical educator, digital health specialist, telemedicine consultant, and healthcare content creator with over 11 years of experience in clinical practice and digital health education. She has extensive experience in evidence-based medical education, telemedicine services, webinar facilitation, and healthcare technology collaboration across Indonesia and Singapore. Her work spans clinical care, healthcare application development, medical reviewing, and public health communication. Right. Tonight, okay, let me just add Dr. Priska on stage. Hi, Dr. Priska.
Hi, Alfred.
Hi. So yeah, let me add your slide in as well. Okay. Yes, it's showing now. Right.
Okay, thank you.
The stage will be yours. Thank you.
Okay, thank you, Alfred. Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Seperti yang sudah dijelaskan tadi oleh Alfred, saya adalah Dr. Priska. Baik, pada kesempatan malam ini saya akan menyampaikan slide saya dalam bahasa Indonesia tentang OSA, yaitu panduan praktis manajemen obstructive sleep apnea untuk FKTP tingkat pertama. Baik, kita mulai saja langsung. Nah, di sini ada mitos tentang mendengkur ya. Jadi kalau di Indonesia, mendengkur itu adalah tanda kalau kita lagi tidur dengan sangat nyenyaknya gitu ya. Jadi mendengkur dianggap sebagai sesuatu yang ya wajar saja dan dianggap sebagai itu tanda kecapean dan seseorang tidur nyenyak, biarin aja. Tapi sebenarnya mendengkur itu adalah sesuatu yang harus kita waspadai. Jadi sebagai tenaga medis, kita juga harus menyampaikan edukasi kepada masyarakat bahwa kebiasaan mendengkur itu bukan sesuatu yang normal. Kenapa? Karena ini adalah tanda atau sebuah gunung es di mana kalau mendengkur terjadi, ini berarti adanya sumbatan di saluran nafas atas seseorang. Nah, ini adalah suatu pertanda kuat pada OSA, di mana yang kita lihat mungkin dia mendengkur sangat keras, kemudian di siang hari mungkin terlihat ngantuk dan sangat lelah, tapi yang tersembunyi di belakang itu yang sering sekali tidak kita ketahui dan juga masyarakat tidak ketahui apa itu, sering terjadi hipoksia intermittent. Kenapa? Karena saat tertidur, otot-otot pernafasan atas rileks, kemudian sering terjadi jatuhnya pangkal lidah dan menutup saluran nafas dan terjadi apnea. Sehingga oksigen masuk ke masuk ke tubuh kita berkurang dan terjadi hipoksia. Kemudian ternyata komplikasinya juga akan merembet ke sistemik seperti hipertensi yang resisten, stroke, bahkan gagal jantung. Nah, kenapa bisa nih dari mendengkur yang disebabkan oleh penyumbatan saluran nafas atas malah terjadi hipertensi, stroke, dan gagal jantung. Nah, karena terjadinya sumbatan nafas atas, kemudian kadar oksigen yang masuk ke dalam tubuh menurun, kemudian kadar karbon dioksida meningkat, ini mengakibatkan memberikan sinyal ke otak bahwa terjadi gangguan kadar gas di dalam darah. Sehingga ini memicu peningkatan saraf simpatis untuk bagaimana menstabilkan kembali kadar gas darah kita tersebut. Nah, saraf simpatis ini menyebabkan apa? Terjadinya vasokonstriksi, agen-agen untuk vasodilatasi menurun, sehingga akhirnya mengakibatkan gangguan pada endotel dan terjadinya arteriosklerosis dan akhirnya bisa mengakibatkan stroke, gagal jantung, dan hipertensi yang resisten. Nah, selanjutnya terjadilah fragmentasi di tidur seseorang, ya. Kenapa? Jadi kalau kita lihat orang mendengkur itu ada yang memang dia mendengkur biasa. Ya, mendengkur atau stridor itu memang adanya hambatan di saluran nafas. Nah, bedanya dengan OSA dia mendengkurnya itu kelamaan itu meningkat, kemudian volumenya itu lebih nyaring daripada suara kita mengobrol biasa, dan ada fase dia tiba-tiba terdiam. Nah, fase terdiam inilah yang fase apnea. Dia tidak bernafas Nah, kita katakan OSA apabila fase apnea itu lebih dari 10 detik. Nah, setelah 10 detik, maka dia tiba-tiba seperti orang tersedak atau mendengkur dengan sangat keras, seperti itu. Nah, itu sebenarnya adalah mekanisme tubuh bagaimana mengembalikan kembali pernafasan kita untuk memasuk oksigen lagi ke tubuh. Nah, itulah dimana pas dia bernafas lagi itu dia adalah fase terbangun. Nah, akibat adanya fase terbangun atau arousal, itu dia tidur dan kemudian terbangun, ini mengakibatkan fase siklus tidur itu terganggu, yang ada fase tidur REM dan non-REM tersebut. Nah, fase tidur yang terganggu ini mengakibatkan tidur kita tidak efektif, di mana kita tahu saat tidur sel-sel tubuh kita memperbaiki diri, kemudian kita rileks. Nah, ini akan terganggu. Akibatnya apa? Fase tidur restoratif kita itu tidak terjadi. Sehingga ketika bangun, kita malah terlihat capek, lelah, dan pada siang hari itu kita merasa ngantuk yang sangat berat. Nah, kantuk ini terjadi akibat dipengaruhi juga dengan aktivasi saraf simpatis yang terus-menerus. Nah, kalau kita lihat per definisi kata, ya seperti yang kita bilang tadi, terjadinya obstruksi atau hambatan saluran nafas atas, ya. Nah, normalnya saluran nafas kita itu tidak ada hambatan. Kita bisa aliran udara masuk dengan baik dan keluar pun dengan baik, sehingga kadar oksigen dan karbon dioksida dalam tubuh itu sesuai, seimbang, normal. Nah, di OSA itu akan terjadi sumbatan di saluran nafas atasnya. Nah, sumbatan ini terjadi akibat apa? Itu banyak hal yang mempengaruhi. Biasanya, ya. Nah, tadi Dr. Siaw juga mengatakan obesitas itu adalah masalah utama, soilnya itu ya, pokok masalahnya. Nah, di OSA, obesitas itu juga faktor risiko terjadinya OSA pada seseorang. Di mana pada orang gemuk, berat badan berlebih, itu memudahkan lemak-lemak mempengaruhi saluran nafas atasnya, karena salah satu yang mempengaruhi juga nanti lingkar leher. Nah, ketika kita tidur, maka kondisi tubuh kita itu rileks. Otot-otot saluran nafas atas pun menjadi rileks. Nah, akibatnya apa? Bagian pangkal belakang lidah juga akan mudah jatuh ke belakang, sehingga bisa menutup saluran nafas atas ini. Selain itu, palatum mole, kemudian faktor tonsil, ukuran tonsil yang besar T3, T4, kemudian posisi telentang itu juga akan mempengaruhi terjadinya sumbatan pada saluran nafas. Nah, tadi sudah saya sampaikan juga, henti nafas yang terjadi itu apabila lebih dari 10 detik. Nah, ini proses terjadinya ya. Pertama akan terjadi obstruksi mekanis. Apalagi kalau posisi tidur seseorang itu telentang, karena ini akan dibantu oleh gravitasi untuk menarik pangkal lidah dan palatum molenya, ya, jatuh ke arah posterior sehingga menutup saluran nafasnya. Lalu ketika saluran nafas menyempit dan tertutup akan terjadi fase apnea. Ya, henti nafas minimal itu 10 detik atau lebih dari 10 detik. Sehingga ketika terjadi apnea, oksigen akan menurun dan karbon dioksida akan meningkat. Nah, akibat terjadinya perubahan gas di dalam darah inilah yang memberikan respon aspiksia kepada otak. Nah, di sini akan terjadi lonjakan hormon stres, kemudian juga merangsang terjadinya aktivasi dari saraf-saraf simpatis sehingga mengakibatkan pembuluh darah berkonstriksi, kemudian jantung berdetak lebih cepat, ya. Dan otak menyuruh tubuh untuk berusaha bernafas semaksimalnya agar aliran udara bisa terbuka kembali. Nah, akibat itulah kita terbangun untuk metode mekanisme supaya oksigen tetap terpenuhi di dalam tubuh. Kalau tidak terjadi terbangun parsial atau fase arousal ini, itu akan lebih fatal lagi untuk tubuh kita. Maka oksigen benar-benar tidak akan masuk ke dalam tubuh nantinya. Nah, apa yang bisa kita lihat nih gejala sehari-hari yang bisa kita lihat dari seseorang yang memiliki OSA? Nah, kalau kita lihat di malam hari, gejala khasnya itu adalah mendengkur yang sangat keras ya. Ini adalah gejala khas dari OSA karena memang ada sumbatan di saluran nafas atasnya. Nah, bedanya dengan mendengkur biasa itu biasanya suaranya tidak lebih keras dari volume kita berbicara. Kemudian untuk mendengkur OSA itu ada fasenya tadi, mulai dari pelan, meningkat, terus berhenti. Itu adalah fase apneunya. Kemudian tiba-tiba seperti orang tersedak atau bernafas dengan susah payah atau bahkan mendengkur dengan lebih kerasnya lagi. Seperti itu. Nah, kemudian ada fase henti nafas yang disaksikan oleh orang lain. Mungkin suami, mungkin istri, orang tua, atau anak. Lalu terbangun tersentak seperti tadi ya, yang merupakan mekanisme tubuh untuk mendapatkan oksigen lagi. Nah, ada juga gejala yang dikatakan berhubungan juga dengan OSA, yaitu nokturia. Nah, kenapa? Apa hubungannya nokturia dengan OSA? Sebenarnya tidak banyak berhubungan, tapi beberapa literatur menyatakan bahwa pada pasien OSA, karena dia memiliki fase arousal yang terbangun, tersentak beberapa kali dalam siklus tidurnya, hal ini mengakibatkan pasien lebih sadar untuk keinginan buang air kecilnya. Ya. Kemudian dengan adanya peningkatan aktivitas saraf simpatis, di mana denyut jantung menjadi lebih cepat, kemudian pembuluh darah menjadi lebih kecil, itu mengakibatkan volume darah yang disaring oleh ginjal juga meningkat, sehingga ini juga meningkatkan produksi dari urin. Lalu tidak hanya di malam hari, ada juga gejala-gejala di siang hari yang bisa kita lihat pada pasien OSA. Karena tidurnya tidak bagus ya, sering terbangun, di siang hari dia akan merasakan kantuk yang berlebihan. Ya, dia bangun dengan keadaan tidak segar. Kemudian dia merasa lelah. Jadi badannya tuh nggak enak, tidak terasa seperti orang bangun tidur, atau sering sakit kepala saat bangun tidur, atau bahkan ada gangguan penurunan kognitif seperti gangguan konsentrasi, mudah lupa ya. Dan sebagainya. Nah, sebagai dokter dan tenaga medis di FKTP tingkat pertama, apa nih yang bisa kita lakukan? Karena saya yakin banyak pasien atau masyarakat Indonesia yang datang itu tidak dengan keluhan saya ngorok atau saya terbangun gara-gara ngorok. Tidak. Karena saya yakin bahwa kita masih menganggap ngorok itu adalah suatu hal yang wajar dan sesuatu yang menandakan bahwa ini tidurnya nyenyak karena kecapean. Nah, ini juga tugas kita sebagai tenaga medis untuk memberikan edukasi kepada masyarakat. Sebenarnya ngorok itu adalah salah satu tanda bahwa saluran nafas atas kita itu menyempit atau terobstruksi atau tersumbat. Pertama, kita bisa melakukan deteksi. Bagaimana cara mendeteksinya? Kita bisa menggunakan kuesioner. Ada 2 kuesioner yang bisa kita gunakan. Stop Bank untuk menilai secara objektif, dan ada ISS untuk menilai secara subjektif, di mana kita lihat bagaimana efek dari OSA ini terhadap kondisi dia terhadap cepat dia tertidur atau ngantuknya di siang hari. Kemudian kita juga nilai antropometrinya, kemudian pemeriksaan THT terfokusnya juga. Lalu untuk tata laksana, setelah kita melakukan deteksi dini, kemudian kita curiga nih ke arah OSA, kita bisa lakukan tata laksana di FKTP tingkat pertama. Pertama, terapi posisi saat tidur, ya. Tadi sudah dijelaskan bahwa posisi telentang itu bisa meningkatkan resiko terjadinya hambatan saluran nafas dan meningkatkan risiko terjadinya OSA. Bagi pasien-pasien yang memiliki faktor risiko seperti berat badan, ya, hipertensi, mungkin bisa disarankan dan dia mengeluh ngorok, bisa disarankan untuk tidur miring bukan telentang. Kemudian kalau memang ditemukan pasien dengan obesitas, kita akan sarankan untuk melakukan manajemen berat badan dengan menurunkan berat badannya. Kemudian kalau ada pasien dengan gejala komorbid lainnya seperti hipertensi, diabetes, kemudian kolesterol, itu juga kita akan obati sesuai dengan keluhannya. Lalu terapi cairan juga, karena terbangun tengah malam itu juga akan untuk buang air kecil juga akan mempengaruhi kualitas tidur, maka disarankan untuk tidak banyak minum sebelum tidur dan lakukan higien pada lingkungan tidur. Nah, ini yang kita bisa lakukan sebagai dokter di FKTP tingkat pertama. Nah, apabila kita menemukan tanda-tanda red flag yang memang harus ditindaklanjuti, maka kita harus merujuk pasien ke FKTP lanjutan. Biasanya kita akan merujuk ke spesialis penyakit dalam. Nah, setelah kita temukan red flag tersebut dan nanti di FKTP tingkat lanjutan akan dilakukan penanganan pemeriksaan yang lebih detail dan penanganan yang sesuai, maka ketika pasien akan dikembalikan ke FKTP tingkat 1, maka kita sebagai dokter di FKTP tingkat 1 melakukan pemantauan rujukan baliknya seperti pemantauan untuk terapi yang diberikan atau efek samping terapi, ataupun nanti kita akan melihat perlu kontrol ulang atau tidak. Nah, apa kuesioner yang kita gunakan? Ini ada 2 kuesioner yang bisa kita gunakan untuk deteksi dini pasien-pasien yang ada di FKTP tingkat pertama. Yang pertama kita bisa pakai stop bank. Ini yang kita lakukan di sini adalah untuk melihat seberapa besar resiko pasien untuk mengalami obstruksi saluran nafas atas. Nah, fokus utama di stop bank ini adalah risiko anatomi dan klinis OSA pada pasien. Jadi kita nilai anatomis dan klinisnya, yang berarti yang kita nilai ini adalah secara objektif. Ada 8 parameternya, maka jawabannya nanti adalah ya dan tidak. Nah, batasnya, skornya, kita bisa mungkin melanjutkan pemeriksaan pasien ke tingkat lebih lanjut jika skor yang didapatkan dari kuesioner stop bank ini lebih atau sama dengan 3. Nah, kuesioner selanjutnya itu lebih ke subjektif. Jadi dampak fungsional yang dihasilkan oleh OSA tadi, ya, urutan OSA tadi karena oksigennya berkurang, akhirnya kita terbangun tengah malam, siklus tidur yang tidak sesuai lagi. Akibatnya apa? Adanya kantuk, rasa kantuk yang berlebihan di siang hari. Nah, inilah di kuesioner ini yang dinilai. Ada 8 situasi yang akan dinilai secara subjektif dengan skala 0 sampai 3. Nah, nanti hasil skornya jika lebih atau sama dari 11, maka ini mungkin kita akan lakukan tindak lanjut ke FKTP lanjutan untuk dilakukan pemeriksaan sesuai dengan gold standarnya untuk menetapkan atau menegakkan diagnosa OSA. Gold standar untuk pemeriksaan ini adalah polisonografi atau PSG. Nah, ini pertanyaan dari stop banknya. As snoring. Nah, kita lihat, kita tanya ke pasien, apakah pasien tidur dengan mendengkur keras? Kerasnya seberapa? Kerasnya itu lebih keras dari saat dia berbicara. Ya. Kemudian sering merasa lelah atau mengantuk nggak di siang hari? Jadi ini jawabannya ya atau tidak. Kalau jawabannya ya, maka dapat skor 1 ya. Kemudian ada henti nafas yang disaksikan ya. Kemudian ada riwayat tekanan darah tinggi. Lalu indeks massa tubuhnya lebih dari 35 kg per meter persegi. Usia di atas 50 tahun dan lingkar leher lebih dari 40 cm dan gendernya laki-laki. Nah, di sini gender laki-laki itu memiliki skor 1. Kenapa? Karena ternyata dilihat dari anatomi dan fisiologi saluran nafas laki-laki dan perempuan, faring pada laki-laki ternyata lebih panjang, dan ternyata faring yang lebih panjang itu lebih mudah kolaps atau jatuh saat otot-otot pernapasan kita berelaksasi. Karena itu dianggap memiliki risiko lebih tinggi dan dikaitkan juga dengan hormon testosteron yang juga mempengaruhi terjadinya OSA ini. Nah, interpretasi skornya 0 sampai 2 itu risiko rendah, jadi tidak perlu penanganan. Paling kalau ada keluhan kita bisa kasih terapi non farmakologis. Nah, kalau lebih atau sama dengan 3, jika dibutuhkan kita bisa melakukan penilaian dan pemeriksaan lebih lanjut. Nah, kuesioner kedua yaitu adalah Epworth Sleepiness Scale. Di sini adalah subjektif ya. Jadi nilainya itu sebenarnya pertanyaannya itu seberapa besar kemungkinan Anda tertidur pada situasi berikut. Efek dari masalah OSA tadi. 0 tidak pernah, 1 sedikit, 2 cukup besar, 3 sangat tinggi. Nah, ini pertanyaan-pertanyaannya. Duduk dan membaca buku atau dokumen, bagaimana? Menonton televisi, bagaimana kemungkinan tertidurnya? Duduk diam di tempat umum seperti rapat, bioskop, bagaimana? Penumpang mobil selama 1 jam tanpa henti, berbaring untuk istirahat di siang hari, kemudian duduk dan mengobrol dengan seseorang, duduk tenang setelah makan siang, dan di dalam mobil saat macet atau lampu merah. Nah, ini dijawab pakai skala ya, jadi ini subjektif orang pasiennya masing-masing. Nah, batasnya adalah lebih atau sama dari 11. Nah, setelah kita melakukan pertanyaan melalui kuesioner tersebut, kita bisa melakukan pemeriksaan terfokus, yaitu pemeriksaan antropometri dan THT. Nah, antropometri kita bisa nilai body mass index-nya, indeks massa tubuhnya. Kalau dari kuesioner tadi lebih dari 35 itu dapat poin 1, tapi dari pemeriksaan kita kalau sudah lebih sama 25 kg per meter persegi itu kita harus waspada ya untuk body mass index ini. Kemudian lingkar leher yang lebih dari 40 cm itu juga besar kemungkinan resikonya tinggi untuk OSA. Nah, ukurnya itu setinggi membran krikotiroid, yaitu daerah antara kartilago tiroid dengan kartilago krikoid. Lalu jika tekanan darahnya lebih atau sama 140/90, kita juga harus waspada. Ya, mungkin saja sebenarnya tekanan darah itu seperti lingkaran timbal balik. Jadi orang yang memiliki hipertensi memiliki peluang tinggi untuk mendapatkan OSA, dan orang yang OSA itu bisa menyebabkan terjadinya hipertensi. Kemudian selain antropometri, kita juga melakukan pemeriksaan pada daerah THT. Nah, di orofaring kita bisa lihat palatumolenya rendah atau tebalkah, kemudian apakah ada uvula yang besar atau memanjang, karena bisa juga akan menyumbat saluran nafas atau mempersempit saluran nafas atas kita. Lalu dari tonsil, ukuran tonsilnya T3 atau T4, di hidung apakah septumnya deviasi, apakah ada polip, apakah ada hipertrofi kongka. Kenapa? Karena kalau terjadi gangguan di hidung, maka pasti kita akan bernafas lewat mulut, ya. Mekanisme tubuh pasti ingin mempasok oksigen sesuai kebutuhan. Jika hidung bermasalah, nafas lewat mulut. Nah, dengan kebiasaan nafas lewat mulut ini juga akan memicu mudahnya terjadi penyumbatan atau relapse-nya bagian belakang dari pangkal lidah kita. Ini juga akan meningkatkan risiko terjadinya OSA tersebut. Nah, ini adalah pemeriksaan baku emas untuk mendiagnosa OSA, yaitu menggunakan PSG tadi, polisomnografi. Nah, di sini yang akan dinilai itu adalah gelombang otak, di mana nanti menentukan tahapan tidur dan aurosalnya. Dia tidur kemudian terbangun. Kemudian dinilai aliran udara dan usaha nafas, ya, untuk membedakan ini apneunya obstruktif atau sentral. Lalu kadar atau saturasi oksigennya, untuk melihat apakah terjadi penurunan kadar oksigen dari baseline-nya lebih besar atau sama dari 4%. Nah, untuk menetapkan ini, jadi AHI ini adalah jumlah kejadian henti nafas per jam tidur. Kalau henti nafas, jadi henti nafas itu dihitung jika dia tidak bernafas besar dari 10 detik, ya. Nah, jika henti nafasnya dalam 1 jam itu kecil dari 5, itu masih normal. Tapi kalau sudah lebih dari 5, itu sudah termasuk OSA, ya. Nah, kalau AHI-nya ini lebih dari 5 dan dia punya gejala klinis, misal seperti yang kita sampaikan sebelumnya, baik itu di malam hari atau di siang hari, mendengkur kah, lelah di siang hari kah, tiba-tiba terbangun, maka itu dengan skor lebih dari 5 saja itu sudah bisa ditegakkan diagnosa OSA. Tapi kalau skornya itu lebih dari sama dengan 15 tanpa gejala pun itu bisa diagnosa OSA. Nah, pemeriksaan ini dilakukan seharian penuh, ya. Jadi tidur itu benar-benar dilakukan penilaian dan bisa dilakukan split, di mana paruh pertama malam itu untuk diagnostik, ya, untuk menetapkan ini tadi. Nah, paruh selanjutnya untuk titrasi CPAP. Nah, untuk pengobatan si OSA kita menggunakan CPAP, di mana nanti dokter akan menilai tekanan yang sesuai untuk si pasien. Nah, bagi kita di dokter di FKTP yang bisa kita lakukan dan kita anjurkan pada pasien adalah pertama, posisi tidur. Posisi tidur diusahakan jangan telentang tapi miring. Kemudian lakukan naikkan kepala sekitar 10-15 cm untuk mencegah pangkal lidah kita tuh jatuh ke belakang dan menutup saluran nafas kita. Lalu untuk cairan dibatasi supaya tidak ada buang air kecil yang berlebihan saat kita tidur. Dan ini yang terpenting, manajemen berat badan, di mana dengan menurunkan berat badan 10% dari berat badan awal, itu ternyata bisa menurunkan indeks AHI-nya hingga lebih dari 20%. Nah, selain itu, tadi kan efek dari penurunan oksigen itu memicu saraf simpatis kita dan juga memicu stres fisiologis di tubuh kita. Nah, salah satu juga yang bisa kita sarankan itu melakukan relaksasi sebelum tidur. Dengan cara apa? Ya, dengan cara mengatur pernafasan. Nah, rekan-rekan bisa sarankan pasien untuk menarik nafas melewati hidung selama 2 detik, kemudian tahan sebentar, lalu buat bentuk mulut itu seperti kita meniup, seperti ini, kemudian keluarkan perlahan lewat mulut selama 4 detik. Lakukan itu terus-menerus ya lebih kurang 10 menit supaya tubuh kita menjadi lebih rileks dan hormon stres kita juga bisa menurun. Intinya waktu yang kita butuhkan untuk mengeluarkan nafas lebih lama daripada saat kita menarik nafas. Jadi tarik, tahan sebentar, keluarkan perlahan melalui mulut kita. Tujuannya apa? Agar karbon dioksida yang terkurung di dalam tubuh kita itu bisa dikeluarkan dengan maksimal. Nah, ini kalau seandainya pasien sudah dirujuk ke FKTP lanjutan, terdiagnosa OSA, dan diberikan tata laksana CPAP atau Continuous Positive Airway Pressure. Ini jalan kerjanya, tadi masalahnya kan di sini, ada hambatan di saluran nafas atas, baik itu karena tertutup lidah atau gangguan lainnya. Nah, caranya ya kita buka hambatan ini. Dengan CPAP kita memasukkan udara bertekanan tinggi sehingga kita harapkan saluran ini terbuka dan udara bisa oksigen bisa terpenuhi dengan baik. Nah, apakah ada indikasi untuk operasi? Ada indikasi untuk operasi jika pertama memang osanya itu obstruksinya disebabkan oleh gangguan anatomi, kelainan anatomi. Misalnya hipertrofi dari tonsil, kemudian ada polip di hidungnya, atau memang gangguan struktur dari orofaring, septumnya yang deviasi atau palatum molenya yang deviasi seperti itu, sehingga dia memang mengganggu aliran udara. Atau pasien yang intoleran dengan penggunaan CPAP seperti itu. Nah, apa sih tanda-tanda red flag di mana kita sebagai dokter di FKTP tingkat 1 harus merujuk pasien ke spesialis penyakit dalam? Pertama, skor tadi. Skor dari kuesioner tadi di mana stop banknya lebih atau sama dari 3 dan ISS-nya lebih sama dari 11. Kemudian ada gangguan atau keluhan lain khususnya di kardiovaskular di mana dia memiliki hipertensi tapi resisten obat. Jadi sudah diberi pengobatan, obat tapi tensinya masih belum normal. Lalu anatomi yang berat seperti tonsilnya, T3, T4 atau deviasi septum yang berat sehingga perlu penanganan lebih lanjut apakah nanti operatif atau bagaimana. Kemudian ada risiko keamanan atau keselamatan. Contohnya dia pengemudi ya, dimana nanti tidurnya tidak berkualitas, ada risiko komplikasi ke kardiovaskular, kemudian dia ngantuk di siang hari, maka ini akan berpengaruh kepada keselamatan dan jiwa seperti pengemudi, pilot, atau operator alat berat. Nah, ketika kita sudah merujuk pasien, maka pasien nanti akan dirujuk balik ke kita. Apa yang akan kita lakukan ketika pasien dirujuk balik ke kita? Pasien yang mendapatkan CPAP, mungkin kita pastikan pasien bisa menggunakan CPAP dengan benar. Kemudian kalau ada efek samping dari CPAP juga kita bisa memberikan solusinya. Nah, apa saja kemungkinan efek samping dari CPAP ini? Pertama, bisa iritasi kulit dan luka. Kenapa? Mungkin ya maskernya terlampau ketat, terjadi gesekan, atau memang pasien alergi terhadap materialnya. Nah, cara mengatasinya bisa bersihkan bantalan maskernya setiap hari atau gunakan pelembab non minyak sebelum tidur. Kemudian bisa juga dicegah dengan ikatannya jangan terlalu kuat, tapi juga jangan terlalu longgar karena bisa mengakibatkan pergeseran. Kemudian masalah hidung, jadi hidung bisa kering, tersumbat atau mimisan. Kenapa? Karena memang kita mendapatkan udara dengan tekanan tinggi dalam jangka waktu yang cukup lama. Ya. Nah, ini bisa diatasi dengan fitur humidifier-nya yang ada di mesin atau kita gunakan semprot salin steril untuk sumbatan keluhan sumbatan pada hidung. Lalu bisa juga menyebabkan mulut kering dan sakit tenggorokan. Kenapa? Kalau kita tidurnya itu bernafas. Jadi kan hidung ditutup masker, kemudian mulut terbuka dan akhirnya kita bernafas dengan mulut, ini bisa memicu mulut kering dan sakit tenggorokan. Mungkin bisa diatasi dengan ada strap yang bisa menutup mulut sehingga memang udara tidak masuk ke dalam mulut. Atau bisa juga nanti berkonsultasi lagi dengan dokter di mana apakah dipertimbangkan untuk menggunakan full face mask. Lalu kebocoran masker itu bisa mengakibatkan mata kering. Kenapa? Mungkin maskernya posisinya tidak benar sehingga karena udara bertekanan cukup kuat, dia bisa lewat dan mengenai mata dan ini bisa mengakibatkan mata menjadi kering. Kemudian ada perasaan-perasaan sesak karena akibat aliran udara yang dipaksa dan selalu menggunakan masker. Dan yang terakhir, aerofagia. Perutnya kembung karena aliran udaranya terlampau kuat dan sehingga bisa masuk ke saluran cerna. Dan ini kita bisa kasih solusi untuk tidur miring atau lebih rileks atau nanti mungkin juga dikonsultasikan dengan dokter DPJP-nya apakah tekanan alatnya akan dikurangi. Nah, mungkin ini slide terakhir dari presentasi saya malam hari ini. Nah, yang harus kita lakukan memang pertama kenali. Jadi, waspadai kalau ada pasien mendengkur dan kantuk di siang hari. Tapi tidak semua ya. Jangan sampai mendengkurnya cuma sekali-sekali langsung kamu coba nih hati-hati nanti komplikasi ke jantung atau dia ngantuk siangnya cuma sekali karena memang tadi malam begadang atau ada acara. Tapi kita waspadai. Kemudian lakukan screening. Kalau kita udah curiga nih, kita lakukan screening menggunakan kuesioner tadi. Insya Allah itu tidak sulit ya. Kemudian kalau memang butuh dan kita curiga dia osak, kita mulai terapi non-farmakologis yang bisa kita lakukan di FKTP tingkat 1, yaitu modifikasi gaya hidup ya. Yang terutama itu adalah kalau orangnya gemuk, turunkan berat badan. Seperti itu. Dan untuk tidur, lakukan relaksasi sebelum tidur, usahakan tidur tidak terlentang, kita usahakan untuk miring, kemudian hygiene tempat tidur, buat tempat tidur menjadi lebih nyaman, kemudian lebih tenang untuk kondisi tidur. Dan yang terakhir, kalau memang ditemukan refleks, hal-hal yang perlu penanganan lebih lanjut, maka kita harus lakukan rujukan ke FKTP tingkat lanjut. Mungkin hanya itu yang saya sampaikan. Saya kembalikan ke Alfred. Thank you, Alfred.
Hello, hello. Thank you so much, Dr. Priska.
Okay, thanks, Alfred.
I can add my Indonesia representative in stage also.
Hello everyone. Yeah, thank you so much, Dr. Priska, and one very wonderful speaker, Dr. Lerly and Dr. Siaw. Ya, Dr. Priska, mungkin sebelum kita tutup webinarnya, mungkin kira-kira Dr. Priska boleh di-summary nggak, Dr. Priska, untuk materinya begitu? Materi Dr.
Oke.
Priska.
Ya.
Tadi kan.
Kalau untuk OSA sendiri, bagi masyarakat Indonesia itu ngorok adalah sesuatu yang dianggap wajar ya. Jadi kita selalu menganggap ngorok itu adalah tanda tidur kita nyaman dan enak ya. Jadi sering sekali baik itu orang awam ataupun tenaga medis menganggap itu bukan suatu masalah. Ternyata ngorok itu adalah tanda suatu masalah yang sangat serius yang kita kenal dengan OSA. OSA kalau dibiarkan tidak hanya masalah ngorok, tapi ini akan memicu komplikasi yang lebih lanjut lagi, bahkan sampai ke kardiovaskular. Jadi di sini karena kita tadi fokus ke dokter di FKTP tingkat 1, maka hal yang harus dilakukan adalah kita mengedukasi pasien bahwa ada suatu kondisi di mana ngorok ini harus dijadikan suatu perhatian khusus. Ya, karena ini ada kalau ngorok itu adalah sesuatu yang abnormal, bukan normal. Jadi kalau terjadi ngorok berarti ada sumbatan di saluran nafas atasnya. Nah, nanti dilihat lagi, ditanya lagi, ada 2 kuesioner yang bisa kita gunakan tadi. Apakah ada kejadian henti nafas saat dia tertidur? Jadi khas sekali untuk si ngorok ini. Nah, kalau ada dan henti nafasnya lebih dari 10 detik, maka sebaiknya kita lakukan pemeriksaan lebih lanjut. Dan yang perlu diketahui juga, obesitas itu sangat mempengaruhi dan memiliki risiko tinggi untuk terjadinya OSA. Mungkin itu yang untuk dokter di FKTP tingkat 1 ya, yang perlu diketahui.
Betul dokter, betul sekali. Karena terutama kita menganggap ngorok itu hal biasa ya dokter ya.
Biasa, itu tandanya dia lagi kecapean dan sekarang tidurnya lagi enak banget gitu.
Padahal bisa jadi pertanda ya dokter ya kalau ada indikasi henti nafas. Ya. Iya dokter ya.
Iya.
Nah, terutama saya nih dokter yang kebetulan juga obesitas kebetulan.
Ngorok nggak Mas?
Jadi ya mungkin obesitas ya dokter, jadi juga sering ngorok juga. Oke. Okay, Alfred, I think that's all. We already, Dr. Priska already summary the session. Yeah, maybe we can close by Alfred lah. Yeah, because you would open. Yeah.
No lah, can lah. We can just close it already. Right. Thank you everyone for joining the CME. So hope everyone have a good evening and good night rest. Right. Thank you.
Thank you, Alfred. Thank you all. Thank you, Nanda.
Terima kasih, Dr. Priska.
Yeah.
Thank you, Alfred. Bye.
Bye.
Bye.